Hi, as you've heard, my name is Marta Boffito, and I'm going to talk about pharmacological considerations in the complex HIV patient. These are my disclosures. So let's just remind each other what we mean for complex. Um, it can be everything that you see in this slide. It can be that we're talking about someone living with HIV with multi-class resistance, someone that has a history of experiencing adverse drug reactions, someone with multimorbidity, therefore on polypharmacy, someone on antiretroviral drugs with a high potential for drug-drug interactions and needing many drugs, someone with mental health concerns. So again, complex can be someone with one of these, two of these, or with them all. For example, let's have a look at this gentleman who is 61 years old and transferred his care from California. So he's been living in the United States for a very long time, up to 6 years ago. And as you can see, he's been HIV positive since 1989. This is probably already a marker of complexity. This is someone who is indeed aging and has been having HIV for a very long time. He's currently on lamivudine once a day, raltegravir twice a day, and atazanavir, unboosted atazanavir once a day. And unfortunately, when it comes to our clinic, he doesn't have any history with him. He doesn't have a transfer of care letter. His viral load, however, is undetectable. And he talks about periods of anxiety and he shares his mental health. And he says that, for example, very recently, he was very anxious because of the change in how atazanavir um, packaging looks like. He recently changed from the branded atazanavir Reatas bottle to a generic blister, and that has caused extreme anxiety, and he stopped his antiretroviral therapy because of that. Also, he's on a quite relevant number of co-medication. He's on mirtazapine, atorvastatin, losartan, endoxazosin for his blood pressure, on tamsulosin for benign prostate hypertrophy. He's on ranitidine. However, at the moment, there is no ranitidine in the UK. And he's trying to manage his heartburn with with antacids because he's on atazanavir unboosted, so he can't take proton pump inhibitors, and he's also on gabapentin. He had chronic hepatitis C that was treated with DAAs 3 years ago and cleared it. His EGFR is 68 and his UPCR is 22. So there is a need to watch his renal function. Recently, he was diagnosed with progressive fibrosing interstitial lung disease. And he's seen at a different hospital for his lung disease. Now, his fibrotic lung disease it doesn't have a great prognosis, and he needs to take numerous co-medications for that too. So he needs methylprednisolone intravenously. As you know, it is a steroid drug that is metabolized by cytochrome P453A4. Although he is not on a booster, he's on atazanavir, which is also an inhibitor of cytochrome P453A4. So his steroid dose will need some adjustments to make sure that he's not overexposed to steroids. He needs mycophenolate. The steroids and the mycophenolate might affect his CD4 count, hence he needs to start PCP prophylaxis with ceftriaxone. He might need to replace gabapentin. He's on that because of a long-term history of peripheral neuropathy. And gabapentin is one of those medications that is actually listed as potentially causing lung fibrosis. So this is something that needs to be reviewed carefully and discussed with the lung colleagues. He needs gastroprotection because of the steroids, and we're here facing in again someone who prefers not to, the potential need of changing antiretroviral therapy, and maybe we should give him an unboosted integrase inhibitors. And also it's really important that we manage his anxiety, but also his potential adverse events to different antiretrovirals in case we're switching to those. So we know about drug-drug interactions and antiretroviral drugs, and we know that some antiretrovirals are characterized by a high potential for drug-drug interactions and others by a lower potential for drug interactions. So those characterized by a high potential are usually the boosted protease inhibitors or elvitegravir cobicistin, so the only boosted integrase inhibitors that we have available for the treatment of HIV. These drugs may increase the concentrations of co-administered drugs, or older NNRTI like efavirenz, nevirapine, etravirenz, which are inducers of certain key metabolic pathway and can lead to the decrease of the concentrations of the comedication. Newer agents are less prone to cause or be victim of drug-drug interactions. So when we talk about drug-drug interactions, we need to remember that one of the drugs is the perpetrator of drug-drug interactions. As I mentioned, either boosted antiretroviral agents or older NNRTIs that induce a certain metabolic pathway. So the perpetrator of a drug-drug interaction causes the decrease, causes the achievement of the concentrations of the drug outside the therapeutic window, either too high and cause toxicity or too low and cause efficacy. And this is what we have been taught and what we've been seeing in clinical practice, in HIV clinical practice over the past many years. As I said, newer, more modern antiretroviral drugs are characterized by a lower potential for drug-drug interactions, and usually they are not perpetrator of drug-drug interactions. However, they may be victims. And this is really important for us HIV clinical care providers to understand that with the more modern antiretroviral drugs, it's the comedication that might affect the antiretroviral drug concentrations. And again, either push them up, make them toxic, or very importantly, push them down and lead to a lack of efficacy of the antiretroviral drug. Let's have a look at some examples. So the drug-drug interactions between antacids containing cations, containing high doses of aluminium, calcium, and so on, can block the absorption of integrase inhibitors, for example, by causing the chelation of the integrase inhibitors that needs to be absorbed at the level of the gastrointestinal tract. Let's have a look at this gentleman, for example, 39-year-old man who has been HIV positive since 2004, and his baseline resistance test is wild type. He has an undetectable viral load and is currently on TAF and emtricitabine and raltegravir 400 milligram twice a day. As you can see from the slide, he has quite a relevant antiretroviral history. He switched many combinations in his life, and the main reason for this switch was tolerability. He never really failed his antiretroviral combination, but it seems that the only combination he can tolerate is the one he's on, which is again TAF, emtricitabine, and raltegravir twice a day. As you can see from his history illustrated in this slide, he's affected by numerous comorbidities, and at the top of the list there is obesity. In fact, he's on a waiting list for bariatric surgery. And this is really important because when someone undergoes bariatric surgery, he needs to receive micronutrient replacement and receive supplements that contain iron, calcium, zinc, copper, selenium, a lot of minerals, first right before and right after the surgery, up to 4 times a day, then less frequently, but probably for the rest of their lives. And this is really important because we need to remember about the drug-drug interactions that causes a potential decrease in the concentrations of integrase inhibitors. And what about unexplained side effects? To further increase the complexity of pharmacological issues in people living with HIV, we never must forget about drug toxicity. Are we actually worried about further weight gain with TAF in someone who, again, is obese and is on a waiting list for bariatric surgery? And although we are unclear about what is the mechanism behind the weight gain seen in some people taking TAF, recently at the Virtual AIDS 2020 conference, the OPERA cohort data were presented showing that when people switched from TDF to TAF, a weight gain of more than 2 kilos over the first 9 months following the switch was measured. So this is again something important to take into consideration. Another example, very topical as we are in the middle of the COVID-19 pandemic, is the fact that new drug-drug interactions or knowledge about new drug-drug interactions may always become relevant. So as you know, dexamethasone has been shown in large COVID-19 clinical trials to be beneficial to prevent complications of and deterioration of COVID-19. For this reason, the WHO guidelines suggest to use dexamethasone and other corticosteroids, but dexamethasone is the one that actually has been shown to be effective in the clinical trials. So let's not forget that dexamethasone, when it's given at multiple doses, might cause an induction of cytochrome P450-3A4. In fact, it is contraindicated with rilpivirine, and when it's given with doravirine, it might be helpful to counterbalance the drug-drug interaction and give doravirine 100 milligrams twice a day. And when given with bictegravir, it might be worth it to keep an eye on virological response in people on bictegravir, because let's not forget that doravirine is metabolized by cytochrome P450-3A4, and bictegravir is partially metabolized by cytochrome P450-3A4, which again can be induced by multiple dexamethasone doses. And let's have a look at another example about potential complex pharmacological issues. So this slide is just to remind us that the incidence of comorbidities in people aging with HIV is higher than the incidence of comorbidities in people aging without HIV. And this is the results of the age-HIV cohort study. So these two cases that I'm illustrating here were literally two cases that I've seen on the same day last week. And the reason why I'm talking about it is because I thought they were perfect for this presentation. I'm talking about two people who have been aging with HIV and now have comorbidities that affect their ability to take antiretroviral therapy. So we are in the context of antiretroviral therapy intake in patients with swallowing difficulties. So one patient was about to undergo a major head and neck surgery. And he was on raltegravir 400 milligram twice a day and darunavir cobicistat. So one pill once a day. So 3 pills over the 24 hours. And very quickly, by discussing the changes that are needed for this person to continue his antiretroviral therapy, we decided that we would crush raltegravir because raltegravir is shown to be bioequivalent when crushed, and we would prescribe darunavir ritonavir, so darunavir liquid and ritonavir powder to replace so the ritonavir to replace the cobicistat and darunavir liquid to replace the tablets of darunavir cobicistat, so that he could continue for months until he was ready again to swallow pills with the either again crushed or liquid or powder antiretrovirals. Similarly, there was another gentleman that was admitted in a elderly home that, because of frailty, was no longer able to swallow. He was stable with an undetectable viral load on abacavir, lamivudine, raltegravir, and darunavir ritonavir, with EGFR of 20 mils per minute, so a remarkable renal impairment, multi-class resistance viruses. So we had to make a quick decision to switch him to the single tablet TAF emtricitabine darunavir cobicistat that can be crushed, and data are available for this, and raltegravir again that can be crushed. And this is although the product of summary characteristics of TAF and FTC of Discovery says that usually the combination of drug is used with an EGFR above 30, but there are some data when people have an EGFR as low as 15. So in conclusion, although maintaining an undetectable viral load has become much easier in clinical practice, in HIV clinical practice, complexity is increasing in HIV clinics because of aging, comorbidities, and definitely it hasn't been easier to look after everybody with HIV as well as we want during the COVID pandemic. Pharmacology knowledge and HIV pharmacist involvement is fundamental, and I would like to underline this because at Chelsea Westminster Hospital, where I work, we have some wonderful pharmacists who help us with all of these clinical complexities. Finally, I think that it is sometimes in some complex patients difficult to move away from boosted protease inhibitors. And this is important to say. So we are moving towards more modern, easier to use drugs. But again, some people still need boosted protease inhibitors, hence our knowledge on drug-drug interactions involving this class of drugs needs to be updated, and the need to know about the management of these drugs remains. Again, moving to more modern drugs is happening, and it could be easier to use them. However, as you have seen in my examples, drug-drug interactions remain a matter of concern in certain clinical scenarios. Thank you very much for your attention.